Hā ki roto, hā ki waho, kia tau te mauri I kokiri nei. I ngā piki, me ngā heke, ko te rangi Māori taku I rāpu nei. Ti hei, mauri ora. Kia ora tātou. I whānau mai ahau he ratonga I te mātaua Māui no rongo mai wāhine taku tama kei tauranga moana ahau I noho ana ko Victoria Blake toko ingoa. I'm Victoria Blake. I am one of the co-chairs of Sustainable Healthcare Aotearoa. And also work for Te Whatuora Health New Zealand as Principal Advisor, Climate Risk and Resilience. It is my pleasure to be the chair of today's hui. And we also have the privilege of our other two chairs joining us, which is Jason Way and Vanessa Neven. So kia ora to them and to all of you that are here today. We have got a pretty exciting chat lineup today. We have Demi Lawrence, who's going to be speaking to Right to Repair medical devices. Hopefully we will have Oliver Hunt, who will be talking about changing healthcare for good at Medsalv. And we have Dr. Martin Minehan, who's going to speak to the syringe recycling at Auckland Hospital. But to get us started today, we're going to kick off with Demi. Demi Lawrence is a prospective graduate of the Master of Sustainable Business at the University of Otago, and she researched right to repair medical devices in New Zealand public hospitals. Her thesis examines financial, manufacturing, single-use and global supply chain barriers to repairability and proposes solutions for a more sustainable and resilient healthcare system. Demi's work emphasises the need for procurement policy changes and the localisation of repair and maintenance to improve repair practices, reduce waste, and enhance cost efficiency in public healthcare. So it is my genuine pleasure to welcome Demi to the chat. Over to you, e hoa.
Thank you so much. That was fantastic. I'm pretty new to Teams, but hopefully I can figure out how to share my screen.
Sorry, if you go up to the top right, just next to the leave button, there's a little button that says share.
Yeah, it's just popping up with some other.
So if you scroll down, you can either share your screen.
Yeah. Oh, got it.
Just hit the screen.
Oh, here we go. Okay, and then I'll bring up presentation. Is that looking like a slideshow on your?
No, I think that's the wrong screen. Hopefully, if you've got your PowerPoint open, you might be able to see it as one of the screens you can share.
Okay. If I stop sharing and reshare.
It's okay. We're used to technical issues, so don't need to worry. There we go. We can see it now. Right, over to you.
Fantastic. Okay, I will just make it. Well, that's my next problem, is making a slideshow. Play from start. Here we go. Okay. Kia ora koutou, everybody. My name is Demi Lawrence, and I'm a Master of Sustainable Business graduate. The main piece of the Masters was an applied research project, also known as a thesis, where I delved into the topic of the right to repair medical devices. So the presentation is going to go into why the right to repair for medical devices is important, what this research involved, what is the right to repair, and then into my research questions. The first one being the barriers to the right to repair for medical devices and the solutions and outcomes that can come from those barriers. So why is it important? At a broad level, healthcare resilience, cost reduction, and sustainability is a key outcome of medical device repairability. The aim of my project was to provide a roadmap for informing and enabling change towards the repairability of medical devices within Te Whatuora. The purpose is to make sure that this supports a more sustainable and resilient healthcare system, which meets the demands of current and future healthcare. So my research was a qualitative study, which means I did a literature review and used interviews as my method. So starting with the literature review, I conducted a deep dive into both grey literature and academic literature in the right to repair field, as well as narrowing down into the medical device repairability sector. So it was international. I looked at it internationally, but tried to narrow it down then to New Zealand, where I found there was a gap in the literature, which suited me well because it meant that I could continue with my research and delve deeper and fill that gap to some degree. So I interviewed 8 very experienced people in the medical device and hospital industry who had direct involvement from 10 to 40 years experience in medical device management or repair. So that ranged from clinical engineers to sustainability advisors, as well as suppliers and remanufacturers. From these 8 interviews, I then did a thematic analysis. So I coded and created sequences for the interviews and the findings that they provided to make connections across them and then, code them into their respective parts, which you'll see in the next coming diagram. This thesis was roughly 6 months, so not a huge thesis, but still could gather plenty of information within that 6 months. It started roughly in September and I finished and handed it in at the end of February. So what is right to repair? Well, the right to repair is the ability for consumers and technicians to fix and maintain devices without restrictions from manufacturers. So in the early 2000s, there was the likes of John Deere and Apple devices where the consumers couldn't repair these things themselves. So advocates began to it created a movement where consumers wanted the right to repair and modify their own devices. This was driven by the fact that there was restrictive manufacturing policies which limited access to repair tools, manuals, and parts. Most of the justification for this from the manufacturers was intellectual property and consumer safety concerns, but the overall aim from the advocates for the right to repair was to reduce waste and costs. So where does the healthcare sector fit into all of this? Well, during the COVID-19 pandemic, as I'm sure all of you have very fond memories of, there was an influx of patients coming into the hospitals and thus a high need for devices such as ventilators, of which had to be pulled out of retirement because of the need and demand for the device. This meant that manufacturers, because of the borders closing, couldn't come in and fix the devices themselves or repair them themselves, and so it meant that it could be enabled in-house technicians to repair these devices. And so this kind of brought up a lot of questions of why can't this always be the case? Why can we not always repair our own devices in-house? And so the right to repair movement also added into the sector of healthcare. So here we have a very in-depth diagram that I created that basically sums up my whole thesis. I will be analysing it and presenting it to you in a bit more concise way so that you can understand it fully. Firstly, starting with the barriers, then the solutions and outcomes. So the first barrier that I found from the interviews was financial. So as many of you are aware, there is limited funding within the public health system for maintenance and repair and replacement. So this was an overall first barrier that was addressed by many of the interviewees. The second was that there is a high cost of manufacturer repairs versus replacement. So replacement is the easy option and makes more economical sense in many cases because of the manufacturer repair costs. So the third section that was found was the financial burden of e-waste disposal. So obviously with a higher turnover of devices, there is more waste and thus cost to disposing of that waste. The second barrier was manufacturing. So there was a lack of access to service manuals, tools, and training, which aligned with the literature and showed that it was a high priority barrier for that, that aligned with the literature. There was also a lot of enforcement of artificial lifespans with discontinued parts and software updates. So most devices on average, and while there's thousands of devices, they do range, the medium is for 7 to 10 years lifespan. But this is set often by the manufacturers where they say we're not going to provide any further parts, or we're not going to enable that device to continue working past this lifespan. And the third barrier for manufacturing was designating devices as unrepairable or single use, which is a growing concern for the medical device industry, to be seeing things as single use or unrepairable. The third barrier, and as we can start to see now, a lot of the barriers do interconnect, and just to keep that in mind, that it's not a strict box around each of these barriers, but they do interconnect and play and add to one another. But the first one is for single use, increased reliance on single use devices. So again, there's that push that there's necessity for single use compared to reusable. Secondly, manufacturers pressure towards single use. So there's a lot of research and documents presented from manufacturers that I found that promoted the use of single-use devices. And thirdly, environmental impacts of single-use waste. So not only the volume where it's getting transported from across the world, but also the end of life resulting, and often many of these parts are from metals or different elements that mean that they can have hazardous result to them. And the last barrier is globalization, which is, in my definition, the global supply chain, because there is a lot of definitions to globalization, but I'm looking at it from a global supply chain barrier, where the delays in obtaining replacement parts, because many of the parts or these large manufacturing companies come from the likes of Germany, China, Australia, and so they're all having to be shipped over, but also the technicians from these manufacturing companies have to come over from overseas or across the country as well. And so there's a dependence on international suppliers, which, as we saw in the likes of COVID-19, this isn't ideal. And lastly, service contracts are restricting in-house repairs. Cool. So looking at it as a whole again, we then move on to the solutions. So the interviewees provided me with two key solutions. The first was procurement policy realignment. So to include repairability and sustainability within the criteria, as that's currently not a featuring factor in the procurement policy from my understanding. Secondly, is mandatory to supply service manuals, training, and resources or tools with the medical devices. And with the current state of the body of Te Whatu Ora being centralised, there is that purchasing power to make these bold procurement policy changes. So the third is to standardise the repairability of SDFs, and all of the above means not to void any warranties, but it would result in more ability for in-house repairs, which kind of links to the second solution of localization of repairs, which strengthens the local repair workforce, which could be seen by repairing in-house or with local third party rather than replacing, and to standardize devices to repair easier, which most devices, let's take the ventilator for argument's sake, it can work the same way regardless of which company you're buying it from. So the cogs or the pieces of equipment within this device will all be the same across. It's whether it's got a different board on the front or different technological advancements to get into the device. But if we standardize these devices, then they'll be easier to repair and get into for in-house or third-party repairers. And finally is to train clinical engineer teams for high acuity device repairs. If we have somebody in Dunedin or Wellington that is trained to come across the country and fix a high acuity device, that would save both time, money and travel to fix these devices within the country and within the Whātua Ora. So I've broken up the outcomes that stem off these solutions into economic, environmental and social, and I'll just quickly run through those. So the first is economic, money talks, so reducing costs by prioritising repair over replacement. There would be long-term savings by having these devices run for longer. There would be increased competition with right to repair policies, reducing repair costs, and we would again be leveraging Te Whātua Ora's purchasing power. The second is environmental, where we would be prioritising reusable over single use. We would be have sustainable redistribution and disposal. Emissions profile would be reduced, extended device end of life, reduced waste to landfill, and reduced global supply chain demand. And finally, the social outcomes would be a national public hospital resilience, strengthen collaboration within third-party repairers and in-house teams, community benefits using local repair industry, improved efficiency by maintaining device repair, and it would create more job opportunities in healthcare. Awesome, so that is the diagram in one, and hopefully that all makes sense, but there is time for questions after. These are the references I used in the second slide, but overall this is everything if you want to delve a bit deeper that I used in my thesis that helped me get to this point. But what helped me more was the interviewees that I interviewed. The 8 of them had a vast amount of knowledge that meant that I could complete this thesis to the depth that I have been able to. And so while they are under privacy and I can't disclose who, but I would just like to shout out to them for their great contribution towards this. Thank you. I just want to, thank you for listening and hear your thoughts, feelings, opinions, and any questions you might have.
That's great, Demi. Well done. If you just want to stop sharing, that would be amazing. Mm-hmm. You should be able to find that. Oh, you figured that one out well quick. Good on you.
I'm onto it now.
Cool. So congratulations, and that's a great, great overview of the research that you've conducted. Just as a little plug, some of you may know I've done a bit of research into right to repair myself, and Sarah Pritchett, who's also on the call, and I have worked together in this space, not for medical devices, but I would just like to share a link I'm going to pop in the chat for a book called Made to Break, which is my big plug for probably one of the best books I've ever read, which is about planned obsolescence, and it really opened my eyes to some of the real concerns we have around consumerism of products. So I'll pop that in the link, which is sort of what you're talking about building in technological lifetimes, etc. So one of the solutions we have to reusing or right to repair medical devices is obviously Medsalv's work that they're doing on DVT sleeves, hover mattresses, and other things, which I was hoping to have Oliver here today to talk a bit about that, but we can maybe ask him back at another time. Is there any questions for Demi?
I was just going to say, Vic, sorry, I sent Ollie an email saying, are you coming? Because I'd heard you say, he said he's going to be here in 5 minutes.
Okay, all right, great. So does anyone have any questions for Demi? Carolina?
Hi there, Demi. Thanks very much for your presentation and congrats on finishing your master's. Can you just talk about who were those participants that you interviewed? Like, where did they work? What's their overall profile?
Yes, I can talk to that, but I have to be quite vast in my
Yeah, no, you don't need to say who they were, but just
No.
yeah.
So I think was 6 of them were within Te Whatu Ora, and 2 of them were redistributors or manufacturers or suppliers. Some of them had multiple hats, so but yeah, their experience was roughly 10 to 40 years. And yeah, I was trying to get the voice of within Te Whatu Ora, and those that were directly using these devices and had the barriers themselves. And then I realized I was getting a bit one-sided, so I included the manufacturer and suppliers, but it is it's only 2 of them, so it was, and they were progressive. So yeah, it was a little bit of a skewed study, but yeah, still got to the bottom of some things. Does that answer your question?
Great.
Thank you.
Martin, hello.
Oh, hi. Thanks, Demi. I think one of the biggest barriers we have is the legislation around medical devices, particularly culpability and liability of should a device fail or cause patient harm. So, I mean, a lot of the devices we use, I mean, I work in the operating theatres, and we end up paying $800 for a battery pack, which has really got half a dozen 18650s in it that I could go down to JCar and buy for $2 each. But I'm not allowed to do that because if I fix it, then I risk causing patient harm. So it would be interesting to see what, I don't know, legislative changes or policy changes need to be established before we can repair things ourselves. Is that something that's been thought about?
Yes, it has. But it is a very tricky, tread lightly topic where you're getting individuals in the firing line potentially for repairing devices. So that's where I felt with the procurement, where you're still using the reputable brands, but it kind of, the onus goes on them if they're not up to scratch with their repairability criteria and they're not allowing technicians to repair with the manuals that they've provided or produced. That to me is a simpler way of getting around that and still not having an individual in the firing line.
Okay, we've got 2 more hands up, so I will go now to Jason and we'll finish with Erin.
And Demi, thank you very much for your great presentation in this topic. It's good to hear, and the special master paper focus on this one. I'm working in dialysis area. We got a lot of single use, the machine dialysis, machine central RO process system. As you mentioned, every certain year we have to replace, which is a huge cost and not a sustainable practice. And you have listed all the barrier and all the potential solution, which is great. And we all come across this kind of thing already. My question is, have you already involved anything, the procurement team in Te Whatu Ora, which is part of thing probably procurement have got some power when they do some contract, do the tender, they might potentially can get a little bit more power to get right to repair. And of course, as Martin previously mentioned, probably the legislation also is the one before all these things happen as well. See.
Yeah, no, great question. I have involved some of the procurement team, but I wanted to get my thesis finalized and graded before, providing this information to those that can use it. But mostly it's, from my understanding, Pharmac is the governing body for the procurement. And yeah, I would love to get in contact with them and share these insights. It's just a matter of getting the final grade back.
Thank you. And last question for Erin today, for you, Demi.
Hi, Demi. Thank you. I'm in the position of being working at a medical device manufacturer and supplier in New Zealand, and my thoughts, there's a lot of complexity there, not just regulations and laws. So what I would suggest, and you probably finished now, but the Medical Technology Association of New Zealand, to give you would have been a good contact to give you a broader knowledge of multiple suppliers, and they've responded to the right to repair bill that's going through select committee at the moment, and I presented this morning to that as well, which is some of the complexities and concerns really from the industry. That's one point. I'm happy to link you with the MTAN's CEO, and they represent around 100 medical device companies in New Zealand. The other point I wanted to raise is the majority, 95% of the medical devices we use in the health service are imported from global manufacturers, and the changes or potential changes that we make here around expectations is not necessarily going to be picked up by manufacturers overseas because of the size of our market. And that's something to put into context as well. Doesn't mean there's not good ideas, but it may be harder to implement because we are a small market down the bottom of the world, which is a reality, unfortunately. Thank you, and I'll put Kushla Smythe's contact details in the chat for you. Thank you.
That would be brilliant. Thank you so much.
Right, thanks, Erin. And those are all fair comments. There are always two or multiple sides to any discussion on any topic. I will pop that book link in the chat though, because that is super interesting if you're wanting to understand planned obsolescence. It may be more simpler for cell phones and laptops as it is for medical equipment, but I don't think it's something we shouldn't be investigating. So thank you for doing some of that investigating for us, Demi, and thank you for being part of this conversation today. Now, I did see that our friend Oliver did join. Are you there? There he is. Okay, great. So I will hand over to him once I have introduced him. If I can find his little chat. Here he is. Right. Oliver Hunt is the founder and chief executive officer of Medsalv, which is a busy changing healthcare for good by remanufacturing used single-use devices for surgical hospitals across Australia and New Zealand, providing job opportunities for people facing barriers to employment in the process. The certified social enterprise is the highest scoring B Corp in the world for medical devices, is climate positive, and was founded in 2017 in Christchurch. In 2024, Oliver was commended for transformational leadership for his role at Medsalv at the Sustainable Business Network's annual awards, which is a great event for any sustainability professional that may get to go. So I'm now hand over to you, Oliver. Welcome.
How's it going? Is that showing on screen? I always have to check with this platform.
It is. Yep.
Cool. I thought I'd just do a bit of what we're up to, how we're going, and now that we're operating across Australia and New Zealand, some of the things that we're learning about what's going on in Australia that we think could make real change easier to deliver in New Zealand, for all the things that we want. So I'm just going to do a bit of a quick refresher so people know what we're all about. So the whole point of Medsalv is to deliver healthcare in a way that cares for the planet in the same way that we care for people, which obviously means bridging a pretty significant gap at the moment, and also create social impact in the way that we do that, and that's through the people that we employ in our remanufacturing facilities. We talk about changing healthcare for good. Well, that isn't just a tagline, that is legitimately something that we're trying to do. And at the moment, there's a lot of things that we think need change. One, we think a linear economy needs to become a circular economy. Two, we think that the incentives aligned with medical device companies need to be aligned with patient care, not with just what makes the most money for those companies. We've got a health system that creates a huge amount of waste, and we need business models that can actually deliver a huge resource efficiency. Pretty much everything in health is really opaque, and we want to move that towards being more transparent. That's one of our values. As touched on before, there's a global supply chain. Most of medical devices have to travel a long way to get to our shores to care for people. We think there's plenty of opportunities to actually make those devices more locally or localize some of the service aspects of those devices. And then finally, we don't think that medical device purchasing decisions in New Zealand and generally in healthcare are made primarily based on what's best for the patient. There's a whole bunch of other factors that drive those decisions as well, and we'd like to see them stripped back towards what's actually important, which is looking after people and looking after our planet. So the problem we solve is the one caused by all those single-use medical devices that could potentially be remanufactured, that are thrown into landfill after one use, after having been imported from somewhere else first. Our solution is pretty simple. I'm not going to bore you with that, but basically, hospitals use the product, we collect it, we remanufacture it, and we return it under our own label, typically for between 30 and 60% of cost saving, depending on the product and where we're doing it. Provides for 4 key benefits: a healthier planet, healthier people because we can make the money go further, healthier spending because it's a lot cheaper and we're actually creating local impact here. That means taxes paid by New Zealanders in New Zealand to support New Zealand, and also people who pulled off the benefit and into the workforce. And then obviously a healthy supply chain because we're actually one of the few companies that is in New Zealand that can call itself a manufacturer of medical devices, even though we're a remanufacturer. We're a B Corp, as we touched on, and we're a registered social enterprise. This is an Australian thing. New Zealand has social enterprises, but it doesn't have a recognised framework that the government recognises. I'm going to touch on that in a second. So we're making some progress, and we're obviously making a fair bit of progress in Australia because we've now started to see some of the biggest companies in the world decide that they're going to follow us, which is great. It would be nice if their approach to that was not to kick us out of conferences to do that, but it's all good. So we've been operating in Australia for 0.8 years, or 300 days since our facility opened, and in New Zealand since our first facility opened, 6.7. We've got a lot of hospitals on board. I think it's just over 120 now across Australia and New Zealand, and we're working with hospitals in all states in Australia. And if you said that in Australia, they'd say that includes New Zealand. So here's New Zealand, and last year we released our first Te Whatu Ora report, which is a report into the impact around New Zealand delivered by people in the public sector. And that showed some of the impact that we're making, and we've managed to make, and I'll get onto that in a second. We ranked every hospital based on their impact and where they were in our model. The top ranking was green. Interestingly, given that our facility is based in Christchurch, the highest performing region in the country was actually the northern region, who delivered the biggest savings. Obviously, this is only over a small number of products, and there's a huge range of things that could be improved here. So we've written them down and provided them to people that matter. The Northern region, as I said, with most of the hospitals in what we call the blue category, so they're collecting and they're purchasing some products back. One hospital in the green category, they're collecting and they're buying back everything that they collect. But that's New Zealand, and that's taken 6.7 years, or maybe a bit longer since I started doing this. Across the ditch, we've been going for 0.8 years, or thereabouts. We've saved over 100K, which is reasonable. We've got 6 large Victorian hospitals, and we've got some large hospitals in other states participating in our programs as well. We remanufactured 40,000 devices, and through our reuse of cardboard boxes, plastic reusable containers to ship products, we've avoided over 400 cardboard boxes. It's probably a little bit on the light side, but we like to underpromise. And there's some of our customers, we've got a bunch of different customers, but this is a snapshot of some of the customers that we're dealing with across Victoria. And you'll see in there some of the sort of big names. Peter MacCallum Cancer Centre, and Peter MacCallum Cancer Centre is where people from New Zealand often go when New Zealand's cancer treatment can no longer support them. These guys are top hospitals across Australia, and they're really embracing sustainability. And there's a strong culture within these bigger organisations of delivering that. Interestingly, they all operate a little bit separate to each other. And then there's a few of those national networks as well. So St John of God Group or Calvary, they're kind of like Southern Cross is to New Zealand, but to Australia. They're a lot bigger. So far in Australia, we've created 10 jobs, and 6 of those jobs are people who face some form of barrier to employment. So they're people who we've employed directly from the government benefit support. So we've obviously picked up, and we're going quite quickly in Australia compared to how we're going in New Zealand, and there are a few different reasons for that. So I thought I'd unpack what they are. First, sustainability is a focus in procurement. It doesn't just come from people bubbling up, it comes all over the place. This is just Victoria and what they're talking about when they talk about sustainability. They have a local jobs first commissioner, they focus on sustainable commitment, sustainable procurement. They have an agency dedicated to sustainability, and they have a social procurement framework. That social procurement framework is to a large extent why Medsalv is such a good B Corp and is a social enterprise, because we thought about that when we were building the company. And by the way, Victoria's local jobs first commissioner means local jobs for anyone in Australasia, and that includes New Zealand. So there's a funny situation where a New Zealand company scores higher in Australia than it does in New Zealand in tendering processes. Contestability. So this is really important. Really hard to innovate in a market that's closed. So that's obvious, and there's tenders that are regularly revisit the market to take on new things at tender timeframes, but also if there's new things come to the market, they run supplementary tenders to say, hey, we see this, we want to add it to our hospitals, and we're going to allow it into the market. I'll touch on the differences to New Zealand in a second. And then in New Zealand, you've got a very different approach to how to contract medical devices. This is what New Zealand is. This is a direct clip from a Pharmac letter last year talking about the benefits of evergreen contracts. Evergreen agreements are the kind of thinking that gets you 2 supermarket chains taking a lot of money off New Zealanders because there's no competition in the market. Evergreen agreements that only need to be updated by mutual agreement are a good way to lock existing suppliers in for a long period of time and take away the incentive to innovate. And I'm telling you guys this because you're the people who advocate for change in the system. You're the people who can think. And you're all New Zealanders, and New Zealanders don't benefit when costs are higher. So those are some of the key points. Those are just some objective facts and some comparisons. I'm not going to tell you what I think should be done here. But for us on the horizon, first and foremost is focusing on Australia, locally innovating there. We're developing our business model. So our current business model is good enough, but we want to make it better. And we've got some successful Australian partnerships with some other companies over there as well. And we're taking advantage of the open market. Yes, it's a bigger market, but it's also more open and it can adopt innovation a little bit better. And part of the reason it can adopt innovation better is because it has a regulatory system. Having a regulatory system means that there is a grade for every product to meet to go into a hospital, rather than an opinion to be secured. at every hospital around the country, which is really important. And in New Zealand, obviously, our appetite to invest and grow in New Zealand will be guided by the ability for us to access the market. If you can't access the market, it's pretty hard to justify a business case that says invest in New Zealand. So this is what we're really looking for people at the top table in New Zealand to start to change. Make the market accessible, make it possible for people to innovate. More broadly than just sustainability, make it possible for people who are building new business models and new products to be able to deliver them to the people in their backyard. And I've sort of flagged there that our regulatory system, which is more of a technical thing around the safety of products, needs to keep up with that. And we think that there's probably some key things that need to change on that front. A couple of reflections, and this is sort of broadly in the system around New Zealand. I think everyone in New Zealand, in the health system or outside of it, wants change. As it pertains to the health system, the system is not really set up in a way that makes it the default thing. But then we've got to reflect that we, including us, are part of that system. And so we all have to act together and work collaboratively to make sure that that change happens. And then the second thing is, and this is a consistent theme across all hospitals in all countries that we work with, the hospitals who deliver the best results always look at getting one run on the board first, rather than planning everything out to the nth degree. And that's a really, really important takeaway. If there's one thing you take away from this in your work as a sustainability professional, it's that getting runs on the board matters far more than getting plans submitted when you're working at the hospital level. It's a lot better to stand in front of real impact and real people and real jobs that you've created and talk about the benefits that you've delivered, and then show how it's possible to do it further forward than to plan. And so, and of course, planning never survives first contact with the enemy. So this is what we see as possible, and hopefully within Health New Zealand or Te Whatu Oro moving forward, this is something that we start to see as a key theme. And ideally, when the best pieces of operational excellence are put to the market, we want to see them standardised and spread across the system. But the first thing to do is to make sure that they're excellent. And then finally, that's all I have to say, but I think just a nod to the fact that the impact that Medsalv creates is not just a function of the work that Medsalv does within its facilities or the people that we employ. It's a function of the work that people all over New Zealand initially and now Australia are doing in their hospitals to make sure products make their way into our collection points and get remanufactured. So we're really, really appreciative of it. And we are, not going to back down from the fact that we want to make positive change in the New Zealand health system, and we're willing to do that. But we do think we're there, and we can help take a leadership position for a better health system for New Zealand. Thanks.
Kia ora, Oliver. Thank you so much for joining us today. I'll just get you to stop sharing if that's okay. We're running a little bit behind, which is pretty normal for us when we do hui like this with such amazing speakers. I wondered if there's any questions for Oliver. He's going to do a really cool thing and just pop a link to the website, his website, in the chat for us, just to make it easier for you to have a little look at what he does. Vanessa.
Hi, Oliver. Just wondering, with the current global transition that we're going through, what do you see then is kind of next steps for yourself as an organization and the potential of everything that's happening in real time right now?
Well, first I want to preface this with there are no tariffs on Medsalv products because we remanufacture them locally within the markets that we deal with. I think obviously the current trade war is a mess, and that's clearly going to damage people. And we can't shy away from the fact that yes, we need trade, and we can't provide for health in New Zealand unless we have those imports. It's just a simple reality that we need that access to those things. And I'm not going to stand here and try and tell you that everything needs to be delivered locally, but I do think there's more opportunity for it. And so, my heart goes out to those people who are currently, and particularly the smaller companies who are importers, struggling to come to terms with what the future of trade will look like. And but particularly those companies who have been stuck into a contract where they have to meet certain criteria, even though there's massive fluctuation out there, and they haven't even been given confirmation of how much, things. So I see that for sure, but I do think that it does underline the fact that local capability and sovereign supply chain capability as a way to strengthen New Zealand and other countries' position is really important, and I think we just need to keep focusing on that. And secondarily to that, we're not a particularly productive nation. It's pretty well espoused that New Zealand is one of the lowest productivity OECD countries in the world, and we should be working on that and working on that in a way that involves our people in the solution. And I think looking at things like I suspect Demi would have talked about in her presentation, having seen her work, is a really good way to do that and provide value and deliver direct economic benefit, which I think we can all agree New Zealand needs more of that. So 2 key thoughts there.
So, all right. Well, thank you so much for joining us today, Oliver. We are going to hear from one of our doctors out of Auckland Hospital, so you're welcome to stay and hang out with us if you'd like to hear what he has got to say. And I'm just I'm trying to spotlight people and do all of that all at the same time. So our third and final speaker for today is Dr. Marty Minehan. He serves as a consultant anaesthetist at Te Tokatumai, Auckland City Hospital, with a subspecialty in women's health anaesthesia. Additionally, he maintains a private practice and provides services at various private hospitals throughout the Auckland region. Dr. Minehan has been actively engaged in healthcare sustainability initiatives for several years. He's contributed to projects aimed at minimising waste in operating theatres, reducing the utilisation of anaesthetic greenhouse gases, and promoting responsible procurement practices. So it's my pleasure and privilege to welcome you today, Dr. Minehan. Over to you.
Cool, thank you. Right, I'll just see if is that sharing now? You can see that?
Yep. Okay,
perfect. So I'm just going to, in the interest of time, skip through this relatively quickly. I think we've got 12 minutes left. So I've been asked to present about our syringe recycling program that we started 4 years ago at ADHB.
You've just muted yourself, my friend.
Is that better?
It sure is.
Okay, right. Wrong way, there you go. So I was saying it was initially sponsored by BD, who are the manufacturers and suppliers of the syringes that we use extensively throughout New Zealand. BD is one of the largest thermoform plastic manufacturers in the world. They produce roughly 700 billion units per annum globally. And they are present in 190 countries and have over 70,000 employees. I don't have any financial interests in BD, by the way. They are interested in product stewardship, and out of most of our suppliers, they have probably one of the more advanced sustainability goals and programs in terms of recycling and manufacturing and reducing waste and so forth. So it was nice to have them actually be part of this project. The idea was that we were looking at the amount of syringes that we were using, and they were previously all ending up in landfill. So that was the white bags that most of us are familiar with. A large percentage of them were ending up in the yellow bins. So those are the hazardous waste bins, which are our most expensive waste stream in the organisation. So the bins we pay for to dispose of per bin, whereas the white waste stream, the general landfill waste stream, we pay for by weight. So we had started a pilot in 2020 with Level 9 and Starship. We collected 260 kilos of syringes. There was a very high staff engagement, and we experimented with different types of bin collection. So on the far right there, you can see a little sort of bin on a stand with a flip-top lid. They didn't last very long, and the flip-top lids broke pretty quickly due to their high use. So we started looking at the bins. I'll show you those shortly, but this is basically the process, is that the syringes are all collected whole, so we don't need to disassemble them. We don't need to take the rubber bungs off them. We don't even need to take the stickers off them. Previous attempts at syringe recycling required that the end user disassembled the syringe. In other words, they'd have to pull the plunger out of the barrel and try and get the rubber stopper off before they could be recycled. So the advantage of this scheme was that it was very easy for the end users to engage in. So the syringes are collected up. They are then shredded into this fine powder, and then they are thermoformed by a company called Future Post into fence post and garden bed. So you can see those there. There are a few issues that we came across during the process. There are different suppliers of syringes that we use. So some of the neuraxial equipment has a different type of plastic in it. And BD do supply some polyethylene syringes. Those are the very small 1 ml syringes. So we had to make sure that we're only using the one type of plastic for the recycling. Here's what I was talking about the bins. We initially started with these flip-top bins, and then we got some syringe silhouettes laser cut into the top of bins to try and encourage people to put the right waste in the right bin, but they too filled up quickly. And the other issue is real estate, floor real estate. So in theatre, floor real estate is a premium, and the more devices and more pieces of equipment you bring into theatre, the quickly it begins to clutter up. So whatever you choose needs to have a very small footprint. So we finally settled on these tall, narrow bins that are used actually in the food industry quite a lot, and you'll see them in chef kitchens and commercial kitchens. And this one has a flip-top lid, and that's what we've been using for the last 4 years. The bins are taken, the theatre bins are emptied into a 120-litre wheelie bin in the main waste room on each theatre floor, and then those bins are collected by Interwaste, who deliver them to Future Post for recycling. When we started this in March 2020, COVID came along, and that just put a kibosh on almost all of our sustainability projects. Nobody wanted to touch anything that came from a hospital during COVID. So Future Post said, nah, we're stopping this. We don't want your COVID-laced syringes in our recycling plant. Because I don't know if you recall, remember there's that whole fomite thing that was going on, and then we all thought it was coming in frozen products from the States, and nobody really understood how COVID was spread in the early days. So that kind of put a kibosh on our recycling. But then after COVID, we restarted it, and it's been very successful. We've learned a few lessons. We learned a lot of lessons from the pilot. We need to educate people. Signage is vital. And also people like feedback, so they like to know that what they're doing is actually having an effect. It's all very good having a recycling scheme, but if the users get no positive reinforcement for their actions, then it's difficult to sustain engagement. So one thing we learned from this is we need to feed back to people, this week we've recycled, how many 100 kilos of syringes. So the program is still running. We fill up about 120 litres of syringes every fortnight. Very high user engagement, particularly with the younger practitioners. I think that one of the reassuring things is that the younger doctors coming through are very focused on sustainability and have much more of an environmental awareness than some of our older practitioners. We are still trying to resolve some contamination issues, and this is a big problem with this program. So you can imagine that if a needle ends up in the recycling waste stream, Future Post just freak out when they see a sharp needle. They also freak out when they see a bit of residual fentanyl in a syringe, for example, or a bit of residual propofol. So in fact, the whole thing almost got stopped because Future Post were very concerned about the frequency of sharps that were ending up in this waste stream. So we learned very quickly that waste segregation in this particular waste stream is paramount. We haven't expanded into other theatres. No disrespect to the current audience, but since the establishment of Te Whare Ora, we've had very little on-the-ground support in the hospital. We used to have a very large sustainability group that met regularly, and you could go to people like Manjula, and she would solve problems for you and connect you to the right people. But that's kind of sort of gone to the wayside since we sort of centralised everything. And next steps, we want to continue with the education. We need to remind people about other types of syringes. And in an ideal world, we'd like to roll it out to all the operating theatres at Te Wharaora and in the northern region. And if that was to work out well, then, you know, in an ideal world, we'd have a nationwide rollout of syringe recycling. I just want to give some props to a group called Ara Manawa. So this is a research studio in conjunction with AUT, where they get design students involved. So they came to us because they heard about the syringe recycling, and they were very interested in trying to come up with a way of detecting contamination in the waste stream. So they had this whole AUT project. There was 2 AUT students that got heavily involved, and I'm just going to quickly see if I can just change to a slightly different share. This one here, is that sharing now? Yep. So they had this whole project where they were trying to help us come up with ways of detecting needles, and then so they had this Raspberry Pi. They developed this Raspberry Pi, which is a small, tiny computer-based system that had a camera on it that would look at the syringe that was put in the receptacle, and through image analysis would try and work out whether it was a syringe, whether there was residual waste in it, whether there was a needle attached to it, and they did a really good job. I'm going to swap back the sharing now. Give me a second. How do I do that? Yep, I'll go back to the presentation. Yep. So hopefully, and this is this. Can you still hear me? Yep. So this is a video of the machine that they invented. So it's worth a look. So you can see here they had this receptacle. You drop a syringe into it. And then, or a needle in this case, and then does an image analysis and works out that that's a sharp, and deflects it not to the recycling bin, and then in this case it works out it's a syringe, and then and it would then put it into the recycling bin. So we were quite excited about this, thinking, well, this could be really great. But unfortunately, due to funding issues, Ara Manawa is due to be disestablished, and so we weren't able to continue developing this project. The other issue, oops, let me see the next slide. The other issue is that BD have expressed some concerns about lack of support. I mean, they're paying to collect these syringes and take them to Future Post. Future Post actually charge BD to take the plastic because Future Post has an excess of people wanting to recycle their plastic. So BD has to pay Future Post to take the syringe material to be recycled. And this is money that is technically being diverted from ADHB's waste stream, so that we're not paying to get rid of these into landfill. And so BD have been saying, well, you know, it'd be nice if you guys sort of came to the party, but that kind of really hasn't happened either. So I'm a little bit concerned about what BD are going to be thinking about what their future plans are with this. But at this stage, we're still recycling the syringes. So importantly, I just want to thank all the theatre staff that were involved, the anaesthetists, the anaesthetic technicians, the healthcare assistants, Interwaste, and that was our ADHB sustainability team back in the day, but they no longer exist, and also Ara Manawa AUT, who unfortunately are going to be disestablished in the coming months. And just finally, this is one of our anaesthetists, Yvonne, with she has a farm, and she uses the posts that are made from our recycled syringes on her farm. So there you go. The good thing about these posts is that they meet a whole lot of requirements in terms of low leachate and other stuff, so they can use them in food production. So vineyards use them, and orchards use them and stuff like that. Okay, thank you very much.